Good morning. Thank you for the invitation to speak today. I've spoken at Dr. Rogsberg Phillips meeting almost every year for nearly 20 years. I really look forward to it, and I want to say I'm very grateful for Dr. Phillips and for the crew that support her and for the wonderful work of Sisters by Choice. I'm a medical oncologist and epidemiologist, and I want to talk to you a little about breast cancer, Black women, and go through some of the numbers. These are my disclosures. I work for Johns Hopkins University, where I'm a professor. I do some consulting for the federal government and for Genentech. None of my talk has anything to do about those consulting arrangements. I also wrote a best-selling book a few years ago, and I still get royalties from it, so I still disclose it. Again, the talk has nothing to do about that. Now, breast cancer epidemiology. What are the numbers and how does it reflect in the population? Leading cause of cancer death is lung cancer, followed by breast cancer, followed by colorectal cancer, followed by pancreatic cancer. Breast cancer is the second leading cause of death among women in the United States. Lung cancer is number one. Many people confuse that. Smoking causes 80+% of all of the lung cancers. We're going to talk about some of the causes of breast cancer. This is the American Cancer Society's estimates for how many people will be diagnosed and how many people will die of breast cancer this year. I used to work for the American Cancer Society. I should also disclose that. There has been a 40% decline in the age-adjusted death rate from 1990 to 2016 among women with breast cancer. 40% decline. That means the risk of dying of breast cancer today is 60% of what it was for a woman in 1990 of the same age. Median age at diagnosis is 58 for Blacks, 62 for whites. About 1 in 9 Black women will develop or be diagnosed with breast cancer in her lifetime, about 1 in 8 white women. For Blacks, it's about 1 in 31 will die, and for whites, 1 in 37. This, I think, is some really important information. This is a modeling study from the National Cancer Institute. And I'm very concerned that so frequently the messages are get screened, and not get adequate treatment. This study tells us that of women, of the 43,000 or so who died this year, 10% of them will die because of a failure either to get screened or a failure of a mammogram to be read correctly or a failure to do something because of that mammogram that should have been done. But it's somewhere between 22 and 27% of the deaths that occur this year are going to be because the women received less than optimal therapy. And we need to have messages about women getting good care. This is a graphic of the age-adjusted death rate for Black women in blue, white women in orange. The other 3 racial ethnic groups are also here. We have Hispanics in yellow, Native Americans in gray, and Asians in light blue. We started collecting Asian, Native American, and Hispanic data in 1990, but we started collecting Black-white data in 1970. This just shows you that Black-white death rates were the same in the 70s, and the disparity only occurred after we learned how to screen and treat for the disease. And the disparity has continued. Indeed, the disparity is greater today than at any time in our history. And keep in mind, there was no disparity, Black versus white, in the 1970s. Since 1990, breast cancer death rates have dropped 23% in Black women, 42% in white women. I noted earlier, 40% for all American women combined. From 1981 to 2010, the Black-white disparity in death rate increased. From 2011 to 2018, the Black-white mortality disparity has remained basically stable at 39 to 40% higher for Blacks versus whites. That's shown again in this graph where the blue and the orange lines are essentially the same width for the last 15 years or so. Now, as an epidemiologist, I like to look at Black women in unusual circumstances. Black women who have access to military hospitals because either they or their husbands did more than 20 years in the service and then they retired, have a much lower Black-white disparity compared to Black and white women in the United States as a whole. The disparity doesn't go away totally, but much of the disparity goes away. This indicates that socioeconomic status, the availability of care, and the ability to use that care is really important for lowering the risk of death in Black women. More evidence of this is the fact that there are 6 states in the United States where there's no Black-white disparity in death rate. This is because the death rates are very low for Black and white women in those states. There's a 7th state where there's no Black-white disparity. That's West Virginia, and that's because the death rate for white women is just as high as it is for Black women, some of the highest death rates in the country. Now, there are 11 states in the United States where white women have a breast cancer death rate higher than Black women in Massachusetts, making this argument that there is no such thing as Black breast cancer or white breast cancer. Now, there is triple negative breast cancer. That's cancer that doesn't express the estrogen, progesterone, or HER2 receptor. Drug treatment options are more limited for triple negative breast cancer. Treatment options are much more limited. Now, about 24% of Black women and 12% of white women who have breast cancer present with triple negative disease. Keep in mind, 76% of all Black women with breast cancer do not have triple negative disease. There is a disparity, Black versus white, but let's talk about that a little bit. Here you can see the graphic in triple negative diseases on the far right, the 24% in the lighter pink and the darker pink being 12% for white women. And you can see that the other types of breast cancer are on the slide as well. Now, factors with a strong correlation for development of triple negative disease include obesity, dietary differences, especially high carbohydrate diet, especially among women who are women when they're children. From birth until the teen years, high carbohydrate diet can translate into a higher risk of breast cancer and triple negative breast cancer, especially when in the 40s and 50s and beyond. Reproductive patterns, multiparity, having many children, early age at first pregnancy, and a huge factor in triple negative disease, not breastfeeding after having a child. Unfortunately, white women tend to breastfeed. It's in their culture. Black women, for cultural reasons as well as for socioeconomic reasons, frequently do not breastfeed. This is a slide looking at obesity from the mid-1980s onward. You can see Black women went from about 35% obese in the late 80s to now about 60% obese. Far more obesity amongst Black women versus white women. Obesity is a cause of triple negative breast cancer. I should also point out that what we should really be looking at is not just obesity, but energy imbalance. The problem is not just obesity. It's obesity, consumption of too many calories, and not enough exercise. Energy imbalance is a 3-legged stool in which one of the legs is obesity. We can use obesity as a marker, but exercise and improving caloric intake, decreasing the amount of calories, more fruits and vegetables compared to high carbohydrate diets would be very helpful. Now, social deprivation studies in Europe and the United States suggest that there are more virulent tumors in the poor. Several studies have correlated higher body mass index, that's obesity, and higher stage of presentation, as well as more aggressive disease. Breast cancer incidence is shown in this slide from 1975 to 2014. This is to show you black women in blue, white women in orange. White women used to have a higher incidence, higher likelihood of diagnosis of breast cancer. And with the obesity epidemic, the incidence of breast cancer in black women has increased such that black and white women now have a very equal chance of diagnosis of breast cancer. Incidence is the same since 2013. The incidence increases in both black and white women, and they involve estrogen receptor positive disease. Triple negative disease has been flat in incidence over the last 40 years, has not been increasing, has not been decreasing. The changes in estrogen receptor positive disease. Now, there's a lot of talk about triple negative disease, but few appreciate that the largest proportion of the black-white breast cancer mortality treatment disparity is due to disparities in the quality of treatment of black women with estrogen receptor positive disease. So that's 76% of women with ER positive disease who are black, who experience a large proportion of the quality of care issues. Of course, for the 24% who have triple negative disease, there are fewer issues with treatment because there are fewer treatments to mess up. This is a study by Mary Jo Lund at Emory looking at women in Atlanta. You see, in the year 2000, 7.5% of black women in Atlanta who had enough access to care that they got screened and diagnosed with a curable, low-stage breast cancer got no treatment within the first year. No treatment at all. Provision of adequate care is a logistical issue and not new science. Now, a substantial number of women of all races and incomes, especially poor women, get less than optimal breast cancer care. No screening or poor screening, poor quality screening. No diagnostics or poor quality diagnostics. No surgery or poor quality surgery. No radiation therapy or poor quality radiation therapy. No chemotherapy or inappropriate dosing of chemotherapy. Racial minorities and the poor are more likely to get less than optimal care. Studies suggest that these disparities are due to cultural differences in the acceptance of that therapy, disparities in comorbid disease. Increasingly, high blood pressure, diabetes, other things make it hard to treat people the way they should be treated for cancer. Too much of a risk. Lack of convenient access to quality treatment, insurance, and transportation issues amazingly interfere with women getting care. And then there's racism, and socioeconomic discrimination, people discriminated against for being poor. Now, I noted earlier, for all women combined, there's about 40% decline in age-adjusted mortality for breast cancer from 1990 to 2018. Truth be told, the decline has varied tremendously from state to state. 20% in some states, 51% in others. Here is a map of the United States. The states in dark blue have had 44 to 51% declines. The states in purple, 20 to 29% declines. Very interesting. We were a very homogeneous world in the 1980s where breast cancer death rates were all about the same in every state, but some states have done better than others. You see, disparities is not just a black-white thing. It's really a Massachusetts versus Mississippi thing. There are white women in certain states who are not doing nearly as well as we could if we had adequate care for all. Just imagine what we could have if we just applied all that we already know about cancer and breast cancer especially to the population. If every human being could get adequate care. And that starts with prevention, moving through screening, to diagnosis, to treatment. Just dream, what could happen if everybody got adequate care? Indeed, in breast cancer, about a third of all deaths would not occur. I thank you. I end with a picture of the old Johns Hopkins Hospital. Have a good day.